Preliminary communication. February 15, 2018. Neurological manifestations among U.S. government personnel reporting directional audible and sensory phenomena in Havana, Cuba. Randel L. Swanson 2, DO, Ph.D. 1,2, Stephen Hampton, M.D. 1,2, Judith Green-McKenzie, M.D., Ph. 2,3, et al. Ramon Diaz-Arrastia, M.D., Ph.D. 2,4, M. Sean Grady, M.D. 2,5, Ragini Verma, Ph.D. 2,6, Rosette Biester, Ph.D. 1,2, Diana Duda, P.T., DPT 2,7, Ronald L. Wolf, M.D., Ph.D. 2,6, Douglas H. Smith, M.D. 2,5. Author Affiliations article information. JAMA. Published online February 15, 2018. DOI 10.1001/JAMA.2018.1742. Editorial comment icon editorial. Comment. Related articles icon related. Articles. Multimedia icon multimedia. Audio 29 hours 14 minutes. Medical findings in U.S. government personnel reporting symptoms after exposure to sensory phenomena in Havana, Cuba. Key points. Question: Are there neurological manifestations associated with reports of audible and sensory phenomena among U.S. government personnel in Havana, Cuba? Findings in this case series of 21 individuals exposed to directional audible and sensory phenomena, a constellation of acute and persistent signs and symptoms were identified, in the absence of an associated history of blunt head trauma. Following exposure, patients experienced cognitive, vestibular, and oculomotor dysfunction, along with auditory symptoms, sleep abnormalities, and headache. Meaning the unique circumstances of these patients and the consistency of the clinical manifestations raised concern for a novel mechanism of a possible acquired brain injury from a directional exposure of undetermined etiology. Abstract. Importance: from late 2016 through August 2017, U.S. government personnel serving on diplomatic assignment in Havana, Cuba, reported neurological symptoms associated with exposure to auditory and sensory phenomena. Objective: to describe the neurological manifestations that followed exposure to an unknown energy source associated with auditory and sensory phenomena. Design, setting, and participants. Preliminary results from a retrospective case series of U.S. government personnel in Havana, Cuba. Following reported exposure to auditory and sensory phenomena in their homes or hotel rooms, the individuals reported a similar constellation of neurological symptoms resembling brain injury. These individuals were referred to an academic brain injury center for multidisciplinary evaluation and treatment. Exposures report of experiencing audible and sensory phenomena emanating from a distinct direction, directional phenomena, associated with an undetermined source, while serving on U.S. government assignments in Havana, Cuba, since 2016. Main outcomes and measures. Descriptions of the exposures and symptoms were obtained from medical record review of multidisciplinary clinical interviews and examinations. Additional objective assessments included clinical tests of vestibular, dynamic and static balance, vestibulo-ocular reflex testing, caloric testing, oculomotor, measurement of convergence, saccadic, and smooth pursuit eye movements, cognitive, comprehensive neuropsychological battery, and audiometric, pure tone and speech audiometry, functioning. Neuroimaging was also obtained. Results of 24 individuals with suspected exposure identified by the U.S. Department of State. 21 completed multidisciplinary evaluation an average of 203 days after exposure. Persistent symptoms, 3 months after exposure, were reported by these individuals including cognitive, N equals 17, 81%, balance, N equals 15, 71%, visual, N equals 18, 86%, and auditory, N equals 15, 68%, dysfunction, sleep impairment, N equals 18, 86%, and headaches, N equals 16, 76%. Objective findings included cognitive, N equals 16, 76%, vestibular, N equals 17, 81%, and oculomotor, N equals 15, 71%, abnormalities. Moderate to severe sensorineural hearing loss was identified in 3 individuals. Pharmacologic intervention was required for persistent sleep dysfunction, N equals 15, 71%, and headache, N equals 12, 57%. 14 individuals, 67%, were held from work at the time of multidisciplinary evaluation. Of those, 7 began graduated return to work with restrictions in place, home exercise programs, and higher-level work-focused cognitive rehabilitation. Conclusions and relevance in this preliminary report of a retrospective case series, persistent cognitive, vestibular, and oculomotor dysfunction, as well as sleep impairment and headaches, were observed among U.S. government personnel in Havana, Cuba, associated with reports of directional audible and or sensory phenomena of unclear origin. These individuals appeared to have sustained injury to widespread brain networks without an associated history of head trauma. Introduction. In late 2016, U.S. government personnel serving in Havana, Cuba, began presenting to their embassy medical unit after experiencing unusual auditory and or sensory stimuli of variable intensity and character, with associated onset of varied neurological manifestations. Initial signs and symptoms pointed toward injury of the auditory system, leading to the establishment of a triage program at the University of Miami centered around otolaryngology evaluation. 80 embassy community members underwent initial evaluation between February and April 2017, and 16 individuals were identified with similar exposure history and a constellation of neurological signs and symptoms commonly seen following mild traumatic brain injury, also referred to as concussion. 1 exposures continued with time, and 8 additional individuals were identified who had similar findings. The U.S. Department of State, Bureau of Medical Services, subsequently convened an expert panel in July 2017, which came to consensus that the triage findings were most likely related to neurotrauma from a non-neutral source and recommended that further investigation into this novel cluster of findings was necessary. The University of Pennsylvania's Center for Brain Injury and Repair was subsequently selected to coordinate multidisciplinary clinical evaluation, treatment, and rehabilitation of individuals identified during initial triage and additional patients with exposure. The purpose of this preliminary communication is to describe preliminary findings from 21 patients who were exposed to the same non-neutral source. 1. Methods. Design. This retrospective study was approved by the Institutional Review Board of the University of Pennsylvania's Perelman School of Medicine, which waived the need for informed consent. The participants signed general consent forms for treatment permitting use of their data in research. Because of security and confidentiality considerations, individual-level demographic data cannot be reported. Clinical approach. The U.S. Department of State directly referred individuals with suspected exposure to the University of Pennsylvania for comprehensive evaluation and treatment. A multidisciplinary team was convened consisting of physical medicine and rehabilitation, occupational medicine, neurology, neuroradiology, and neurosurgery. Each specialist independently obtained clinical histories and conducted comprehensive assessments. Reported signs and symptoms were extracted from these interviews. Based on individual clinical indication, additional referrals were made to vestibular physical therapy, neurooptometry, neuropsychology, occupational therapy, speech therapy, audiology, otolaryngology, and sleep medicine for focused evaluation and treatment. Patients were referred to the University of Pennsylvania for clinical care, as opposed to enrollment in a structured research study. The box shows an abbreviated list of objective measures used during clinical assessments and supplements for additional information. 229. Box. Examples of standardized measures used in clinical assessments. Cognitive. Boston Diagnostic Aphasia Examination 2. California Verbal Learning Test 2 & Edition 3. Grooved Pegboard 4. Test of Memory Malingering 5. Trail Making Test, Parts A and B 6. Wechsler Adult Intelligence Scale I.V. 7. Wechsler Memory Scale I.V. 8. Mood. Beck Depression Inventory, 2nd edition 9. Beck Anxiety Inventory 10,11. Frontal Systems Behavior Scale 12. Post-Traumatic Stress Disorder Checklist 13,14. Balance and Vestibular. Functional Gait Assessment 15. Activities Specific Balance Confidence 16. Balance Error Scoring System 17. Clinical Test of Sensory Organization and Balance 18,19. Dizziness Handicap Index 20. Computerized Dynamic Posturography 21,22. Caloric Reflex Test 23,24. Vision and Oculomotor. Formal Evaluation of Vergence and Accommodation 25,26. Convergence Insufficiency Symptoms Survey 27. Developmental Eye Movement Test 26,28. Vestibular, Ocular Motor Screening 29. Measures were used based on clinical indications, therefore, every patient did not complete all measures in this abbreviated list. Cognitive, neurobehavioral, and mood evaluations. When clinically indicated, comprehensive neuropsychological assessments were conducted by experienced neuropsychologists, who were not blinded to patient status. Neuropsychological test batteries included assessment of the following domains: 1. Auditory attention, 2. Auditory and visual working memory, 3. Auditory and visual memory, 4. Visual spatial perception, 5. Visual motor construction, 6. Motor function, 7. Language function, 8. Executive function, 9. Processing speed, 10. Academic achievement, 11. Reasoning, 12. Mood functioning, and 13. Effort. Box and the appendix in the supplement. Following neuropsychological testing, individuals with cognitive deficits were referred for cognitive rehabilitation with occupational therapy, speech therapy, or both, depending on the individual clinical indication. Cognitive rehabilitation was intentionally not started prior to completion of neuropsychological testing to avoid affecting results. Balance and vestibular evaluations. Clinical evaluations identifying balance abnormalities prompted referral to vestibular physical therapy. Focused vestibular evaluation included expert clinical assessment and the use of validated measures of static and dynamic balance. Box 1521. Also per clinical indications, patients were referred to audiology for comprehensive evaluation of the peripheral vestibular system, including caloric reflex testing. 23,24 individuals confirmed to have a unilateral peripheral vestibulopathy, relative vestibular reduction of greater than or equal to 25% on caloric reflex testing, underwent magnetic resonance imaging, MRI, of the head with and without gadolinium contrast, with focus on the internal auditory canals in addition to the MRI sequences detailed. Oculomotor evaluations. Individuals found on clinical evaluation to have abnormalities of oculomotor function were referred to neurooptometry for further evaluation and treatment. Oculomotor function was quantified using the following standard optometric clinical measures. Box 25,26 Vergence testing included step vergence with prism bar, vergence facility with prisms, and near point of convergence. Accommodative testing in non-presbopic patients included amplitude of accommodation, accommodative facility with plus and minus lenses, and accommodative lag. Pursuit and saccadic testing was done qualitatively to assess accuracy of tracking eye movements and whether symptoms were provoked as with vestibular, ocular motor screening. 29 Saccadic speed and accuracy were quantified using the developmental eye movement test, 26,28 a timed visual verbal test. Diagnoses of accommodative, vergence, and or saccadic, pursuit dysfunction were made using standardized criteria, in conjunction with symptomatic reporting, 26 which were quantified using the Convergence Insufficiency Symptoms Survey. 27 Auditory evaluations. Audiometry evaluations were performed prior to referral for care at the University of Pennsylvania. However, when patients had balance function testing as described here, comprehensive audiology evaluation included both pure tone and speech audiometry. Imaging evaluations. Initial conventional MRI sequences were acquired at 3T on a Siemens Magnetom Prismafit scanner, and included high-resolution sagittal three-dimensional MP-RAGE, T2 space and flare space, coronal two-dimensional T2 weighted imaging, axial two-dimensional diffusion weighted imaging, and axial T2 gradient echo. Resulting images were clinically interpreted by neuroradiology clinicians. Results. There were 21 individuals evaluated, 11 women and 10 men, with a mean age of 43 years. Multidisciplinary evaluations began an average of 203 days, range, 331 days, median, 189 days, interquartile range, 125 days, following exposure, Table 1. Exposure. For 18 of the 21 individuals, 86%, there were reports of hearing a novel, localized sound at the onset of symptoms in their homes and hotel rooms, Table 2. Affected individuals described the sounds as directional, intensely loud, and with pure and sustained tonality. Of the patients, high-pitched sound was reported by 16, 76%, although 2, 10%, noted a low-pitched sound. Words used to describe the sound include buzzing, grinding metal, piercing squeals, and humming. The sounds were often associated with pressure like N equals 9, 43%, or vibratory, N equals 3, 14%, sensory stimuli, which were also experienced by 2 of the 3 patients who did not hear a sound. The sensory stimuli were likened to air baffling inside a moving car with the windows partially rolled down. Both the sound and sensory stimuli were often described as directional in that the individuals perceived a distinct direction from which the sensation emanated, hereafter referred to as directional phenomena. Further, the directional phenomena appeared to be localized to a precise area, as individuals, N equals 12, 57%, noted that after changing location, the sensation disappeared and the associated symptoms reduced. 5 individuals, 24%, reported covering their head and or ears, although doing so did not result in attenuation of the directional phenomena. Accurately determining the dose and duration of exposure has been difficult because of the limitations of patient recall. Some patients were awakened by sounds and were unsure of the start of the event. The shortest reported event involved 2 10-second pulses reported as a single exposure episode, whereas other patients reported that they perceived sound continuously for longer than 30 minutes. Owing to security concerns, further details of potential dosage cannot be provided. Of the affected individuals, 95%, reported immediate onset of neurological symptoms associated with directional phenomena, Table 1 in the supplement. 1 individual awoke from sleep with acute symptoms, including headache, unilateral ear pain, and hearing changes, but did not perceive directional phenomena. From days to weeks after exposure, individuals reported that they experienced the onset of additional cognitive, neurobehavioral, mood, and physical symptoms. 20 individuals, 95%, reported that they experienced persistent, 3 months, symptoms, and 18 individuals, 86%, exhibited objective clinical manifestations in 6 predominant domains, Table 3. cognitive, neurobehavioral, and mood findings. Persistent cognitive manifestations were reported by 17 individuals, 81%. Subjective symptoms included memory problems, N equals 16, 76%, feeling mentally foggy, N equals 16, 76%, impaired concentration, N equals 15, 71%, and feeling cognitively slowed, N equals 14, 67%, Table 3. In addition, they reported neurobehavioral difficulties including irritability, N equals 14, 67%, nervousness, N equals 12, 57%, feeling more emotional, N equals 11, 52%, and sadness, N equals 5, 24%. For at least 6 individuals, 29%, a clear change in work performance was noted by supervisors and colleagues. Table 1 in the supplement. Individuals also reported a good day bad day pattern where significant cognitive or physical exertion would be followed by exacerbation of their symptoms for several days. Cognitive symptoms, as well as disequilibrium and headache, reportedly were also frequently exacerbated by cardiovascular exercise. Multidisciplinary evaluations raised concern for cognitive impairment in 16 individuals, 76%. Prior to referral, 4 of these individuals underwent neuropsychological evaluation, data not shown as generated outside of the University of Pennsylvania. Repetition of comprehensive neuropsychological testing is precluded within 1 year due of practice effects when material is presented within this time frame. With previous exposure to material, the individual may score higher on a repeated neuropsychological evaluation within 1 year. Neuropsychological assessments were performed on 10 individuals after referral. Of those, interpretation was ongoing in 4 at the time of this publication. For their preference, 2 individuals did not complete neuropsychological testing. For the 6 individuals with complete neuropsychological testing data and analysis at the University of Pennsylvania, all had significant areas of cognitive weakness and or impairment, tables 2, 3, and 4 in the supplement. Impairments were found in executive function, N equals 6, motor function, N equals 5, auditory and visual memory, N equals 4, visual spatial perception and visual motor construction, N equals 4, auditory attention and working memory, N equals 3, language, N equals 3, processing speed, N equals 4, and reasoning, N equals 1. All individuals demonstrated a high level of effort during testing and had intact cognitive domains including visual working memory and academic achievement. Neurobehavioral function was evaluated using the Frontal System Behavior Scale, a self-report measure of frontal lobe dysfunction. Specifically, comparing before and after exposure retrospectively via patient recall and self-report, individuals noted apathy, N equals 5, executive dysfunction, N equals 4, and disinhibition, N equals 2. 2 individuals met criteria for post-traumatic stress disorder and endorsed severe levels of anger on the brief mood survey, one of whom also endorsed moderate to severe levels of depression and anxiety. Balance and vestibular findings. Individuals described acute nausea, N equals 7, 33%, and dizziness, N equals 5, 24%, during exposure, which continued to progress in the subacute and persistent stages. Acute stage equals during or hours following exposure, subacute stage equals days to weeks after exposure patient recall, and persistent stage equals more than 3 months after exposure. Specifically, more than 3 months after exposure, individuals reported a higher prevalence of dizziness, N equals 13, 62%, and nausea, N equals 7, 33%, in addition to general balance problems, N equals 14, 67%, Table 3. These symptoms were exacerbated by walking quickly, tasks involving head movements, complex visual environments, or in some cases while simply standing still. Balance symptoms were also worsened with eyes closed or in low light conditions. Clinical examinations raised concern for balance impairment in 17 patients, 81%, prompting referral to vestibular physical therapy. Focused vestibular evaluations demonstrated impairments in static postural stability, N equals 16, 76%, dynamic balance, N equals 16, 76%, and the vestibulo-ocular reflex, N equals 15, 71%, tables 5, 6, and 7 in the supplement. Patients with the most severe balance impairments on clinical evaluation underwent caloric reflex testing, which demonstrated peripheral vestibular dysfunction in 4 of 13 patients evaluated. MRI findings focusing on the internal auditory canals on these 4 patients were normal. Taken together, these balance symptoms and evaluation findings are consistent with central and, in some cases, peripheral vestibular abnormalities. Oculomotor findings. Of the individuals with persistent symptoms, 16, 76%, reported visual problems, Table 3. Light sensitivity, N equals 13, 62%, and difficulty reading, N equals 12, 57%, were also frequently reported. Eye strain, N equals 11, 52%, was experienced particularly with reading and was associated with headaches, disequilibrium, and nausea. Clinical examinations raised concern for oculomotor dysfunction in 15 individuals, 71%, prompting referral to neurooptometry. The most common findings confirmed on focused oculomotor evaluation were convergence insufficiency, N equals 11, 52%, abnormal smooth pursuits, N equals 11, 52%, and saccadic dysfunction, N equals 10, 47%, tables 8 and 9 in the supplement. Similar to vestibular testing that provoked symptoms, oculomotor examination elicited headache and disequilibrium. Auditory findings. At the onset of the directional phenomena, affected individuals reported hearing a loud sound, N equals 18, 86%, associated with ear pain, N equals 7, 33%, and tinnitus, N equals 6, 29%. Within days to weeks following exposure, individuals continued to report tinnitus, N equals 12, 57%, and ear pain, N equals 5, 24%, with the addition of a change in hearing, N equals 7, 33%, and sensitivity to noise, N equals 5, 24%. More than 3 months after exposure, sound sensitivity was the most common auditory concern, N equals 14, 67%, followed by tinnitus, N equals 12, 57%, and ear pressure, N equals 8, 38%. While 9 individuals, 43%, reported persistent hearing reduction, pure tone audiometry, including pure tone average and word identification, revealed moderate to severe sensorineural hearing loss in 3 individuals, 23%, table 10 in the supplement, who were fitted with hearing aids. For 2 individuals, the moderate to severe sensorineural hearing loss was unilateral and corresponded with the site of peripheral vestibular dysfunction on caloric testing. Otoscopy and tympanometry findings were unremarkable. Sleep. Individuals commonly reported issues with sleep, N equals 18, 86%, including reduced sleep duration, N equals 15, 71%, and difficulty falling asleep, N equals 14, 67%. In addition, individuals experienced significant daytime fatigue, N equals 16, 76%. Most individuals required pharmacological intervention to improve subjective report of sleep architecture, N equals 15, 71%, table 11 in the supplement. Headaches. At the initiation of directional phenomena exposure, 8 individuals, 38%, reported immediate onset of headache, while 5, 24%, reported intense head pressure. In the days to weeks following exposure, 17 individuals, 81%, developed headaches, with 16, 76%, experiencing persistent headaches longer than 3 months after exposure, Table 3. In the persistent stage, headaches were reported to be exacerbated or associated with cognitive tasks, N equals 13, 62%, rehabilitative therapies, N equals 11, 52%, photophobia, N equals 9, 43%, and phonophobia, N equals 6, 29%. Patients with antecedent headaches were able to differentiate the character of these headaches from that of their standard headaches. Headaches were generally reported to improve with medications, N equals 12, 57%, and appropriate therapies for oculomotor and vestibular impairments, E Table 11 in the supplement. Imaging. MRI neuroimaging was obtained in all 21 patients. Most patients had conventional imaging findings, which were within normal limits, at most showing a few small nonspecific T2 bright foci in the white matter, N equals 9, 43%. There were 3 patients with multiple T2 bright white matter foci, which were more than expected for age, 2 mild in degree, and 1 with moderate changes. The pattern of conventional imaging findings in these cases was nonspecific with regard to the exposure, insult experienced, and the findings could perhaps be attributed to other pre-existing disease processes or risk factors. Advanced structural and functional neuroimaging studies are ongoing. Rehabilitation and return to work. Individualized rehabilitation programs were developed, which included combinations of neuro-optometric rehabilitation, N equals 14, 67%, vestibular physical therapy, N equals 17, 81%, and cognitive rehabilitation with speech pathology and/or occupational therapy, N equals 13, 62%. The most symptomatic patients, N equals 14, 67%, requiring multiple therapies did not return to work. Vestibular physical therapy sessions focused on balance retraining, static and dynamic posture control with substitution via visual and somatosensory systems, gaze stabilization exercises, habituation, smooth pursuits, and saccadic eye movement exercises. Patients treated with vestibular rehabilitation have demonstrated a positive response with improved balance and reduction of disequilibrium. Formal neuro-optometric rehabilitation, including manipulation of disparate divergence and accommodative amplitude and latency, has been used to treat ocular motor deficits. Rehabilitation for abnormal smooth pursuit and saccadic dysfunction was coordinated between neuro-optometric rehabilitation, vestibular physical therapy, and occupational therapy. Vestibular physical therapy focused on oculomotor function with the body in motion, and occupational therapy emphasized functional tasks such as visual scanning in a simulated work environment. Following comprehensive neuropsychological testing, a formal cognitive rehabilitation program was initiated in the form of occupational therapy and/or speech therapy. Early return to work with intensive cognitive loading led to an exacerbation of neurocognitive, vestibular, and visual symptoms in 7 individuals, 33%. Individualized return to work plans were designed to reintegrate individuals using a stepwise process and appropriate work modifications. Discussion. Preliminary findings are described of a case series of individuals stationed in Havana, Cuba, nearly all of whom reported directional audible and or sensory phenomena that was followed by the development of a consistent cluster of neurological signs and symptoms. The clinical manifestations may represent a novel clinical entity, which appears to have resulted from a widespread brain network dysfunction, cognitive, oculomotor, and central vestibular, as seen in mild traumatic brain injury, or concussion, 30, as well as injury to the peripheral vestibular system in some cases. It is currently unclear for how the noise is related to the reported symptoms. In particular, sound in the audible range, 20 Hz - 20,000 Hz, is not known to cause persistent injury to the central nervous system, and therefore the described sounds may have been associated with another form of exposure. Cognitive symptoms, including difficulty remembering, N equals 16, 76%, and feeling cognitively slowed, N equals 14, 67%, were the most problematic for individuals in this series more than 3 months after exposure, with neuropsychological testing identifying impairments in at least one cognitive domain in all 6 patients who completed neuropsychological evaluation to date, tables 2, 3, and 4 in the supplement. Cognitive difficulties interfered with these patients' ability to multitask, process information quickly with accurate recall, solve problems, and perform rapid decision-making. Compared with vestibular and oculomotor impairments, cognitive impairments are often the slowest to improve following acquired brain injury, which was observed in this series. Therefore, extended cognitive rehabilitation with emphasis on return to work was used. In addition, it is not uncommon for patients with neurological injury resulting in cognitive impairment to have mood disturbances such as depression, anxiety, and/or post-traumatic stress disorder. Mood dysfunction can directly result from acquired brain injury or develop in response to the precipitating event and novel deficits. 31-33. The presence of subjective neurological symptoms presenting in a cohesive community has raised concerns for collective delusional disorders, including mass psychogenic illness. However, neurological examination and cognitive screens did not reveal evidence of malingering, and objective testing and behavioral observations during cognitive testing indicated high levels of effort and motivation. Several of the objective manifestations consistently found in this cohort, such as oculomotor and vestibular testing abnormalities, could not have been consciously or unconsciously manipulated. Furthermore, mass psychogenic illness is often associated with transient, benign symptoms with rapid onset and recovery often beginning with older individuals. 34-35 In contrast, the Havana cohort experienced persisting disability of a significant nature and are broadly distributed in age. Rather than seeking time away from the workplace, the patients were largely determined to continue to work or return to full duty, even when encouraged by healthcare professionals to take sick leave. While not systematically excluded, viral etiologies, chemical etiologies, or both associated with acute onset of persistent neurological impairment and peripheral vestibulopathy with the directional nature of exposure descriptions are not readily apparent. No other manifestations of viral illness, such as preceding fever, were identified. It is unlikely a chemical agent could produce these neurological manifestations in the absence of other organ involvement, particularly given that some individuals developed symptoms within 24 hours of arriving in Havana. There are important considerations in this investigation. In particular, the anatomic substrates causing the symptoms have not yet been identified. This may represent a significant challenge because even the designation of concussion is not yet a true diagnosis, as no definitions include the underlying cause. Nonetheless, there is an emerging consensus that concussion, or mild traumatic brain injury, is a type of brain network disorder, based on classic symptoms, e.g., slowed processing speed and memory dysfunction, as well as changes in the white matter tracts and consecutive connectivity, as detected with advanced neuroimaging studies. 30-36. Beyond the absence of blunt head trauma, there were additional notable differences between the manifestations observed in the Havana cohort and characteristic acute and persistent symptoms of concussion. For example, individuals experienced unilateral ear pain and tinnitus after exposure, and some were later detected to have a unilateral peripheral vestibulopathy, along with central vestibular dysfunction, a finding uncommon in concussion. Further, studies have reported that while most individuals following concussion have a relatively rapid full recovery, at least 15% are thought to experience characteristic persisting symptoms. 37-38 In contrast to classic concussions, most patients referred following suspected exposure in Havana exhibited significant impairment that persisted for months with no significant improvement in multiple cases until rehabilitation was initiated. For practicing clinicians, If a patient presents reporting a similar potential exposure and symptoms similar to those observed in mild traumatic brain injury, in addition to a thorough history, objective evaluation should include screening assessments of vestibular, oculomotor, and cognitive functioning. Based on findings of this assessment, appropriate referrals to subspecialists should be considered, including neurorehabilitation physiatry, vestibular physical therapy, neurooptometry, neuropsychology, and audiology. Limitations. This study has several limitations. First, due to the sensitive nature of this publication, certain details typically reported in a case series of exposure were omitted, including specifics about geography, relationships between individuals, and individual demographics. Second, because these patients' first evaluation was elsewhere, each patient did not undergo each of the tests described. In particular, neuropsychological characterization was incomplete at the time of publication. Preliminary results were presented given the importance and strong public interest in this case series. Third, the rehabilitative course of this Havana cohort may not be representative because this represents a referral population. There may be additional individuals exposed while in Havana, Cuba, who have not been identified due to subtler manifestations that either resolved spontaneously or did not prompt presentation for medical treatment. Therefore, the actual number of individuals exposed is unknown, and the relative dose of exposure that causes acute and chronic symptoms remains unclear. Conclusions. In this preliminary report of a retrospective case series, persistent cognitive, vestibular, and oculomotor dysfunction, as well as sleep impairment and headaches, were observed among U.S. government personnel in Havana, Cuba, associated with reports of directional audible and or sensory phenomena of unclear origin. These individuals appeared to have sustained injury to widespread brain networks without an associated history of head trauma. Back to top. Article information. Corresponding author, Douglas H. Smith, M.D., Department of Neurosurgery and Center for Brain Injury and Repair, University of Pennsylvania, Perelman School of Medicine, 3320 Smith Walk, 105 Hayden Hall, Philadelphia, Pennsylvania 19104, smithduat.apane.edu. Accepted for publication, February 8, 2018. Published online, February 15, 2018. DOI, 10.1001/JAMA.2018.1742. Author contributions. Dr. Smith and Swanson had full access to all of the data in the study and take responsibility for the integrity of the data and the accuracy of the data analysis. Concept and design, Swanson, Hampton, Smith. Acquisition, analysis, or interpretation of data, all authors. Drafting of the manuscript, Swanson, Hampton, Biester, Duda, Smith. Critical revision of the manuscript for important intellectual content, all authors. Statistical analysis, Swanson, Hampton, Smith. Administrative, technical, or material support, all authors. Supervision, Swanson, Smith. Conflict of interest disclosures, all authors have completed and submitted the ICMG form for disclosure of potential conflicts of interest. Dr. Green-McKenzie reported receiving grants from Health Resources and Services Administration and the National Institute for Occupational Safety and Health. No other disclosures were reported. Disclaimer: support for this article was provided by the U.S. government in the form of background information and referral of patients. The findings and conclusions are those of the authors and should not be construed as officially reflecting the views of the U.S. Department of State. Additional contributions. We are grateful to the following individuals, who did not receive compensation for their role in the study: Michael Galloway, OD, Neurooptometry Consultant, Department of Optometry, Salus University, Philadelphia; Mary Fran Matten, OTR/L, CPIS, MSCS, Occupational Therapy Consultant, Penn Therapy and Fitness, Good Shepherd Penn Partners, University of Pennsylvania, Philadelphia, Darlene Mancini, CCCSLP, Speech-Language Pathology Consultant, Pen Therapy and Fitness, Good Shepherd Pen Partners, University of Pennsylvania, Philadelphia, Danielle Sandsmark, MD, PhD, Neurology Consultant, Department of Neurology, University of Pennsylvania, Perelman School of Medicine, Philadelphia, Grant Liu, MD, Neuro-Ophthalmology, Department of Neurology, University of Pennsylvania, Perelman School of Medicine, Philadelphia, Nora Johnson, MBA, MS, Doctor of Psychology, Neuropsychology Consultant, Department of Physical Medicine and Rehabilitation, University of Pennsylvania, Perelman School of Medicine, Philadelphia. Sherry Davis, Audiology Consultant, Department of Otorhinolaryngology, University of Pennsylvania, Perelman School of Medicine, Philadelphia. Michael J. Ruckenstein, MD, Otorhinolaryngology Consultant, Department of Otorhinolaryngology, University of Pennsylvania, Perelman School of Medicine, Philadelphia. Charles By, MD, Sleep Medicine Consultant, Department of Neurology, University of Pennsylvania, Perelman School of Medicine, Philadelphia. David M. Raisin, MD, PhD, Sleep Medicine Consultant, Department of Neurology, University of Pennsylvania, Perelman School of Medicine, Philadelphia. Sharon Scudrodan, MD, Sleep Medicine Consultant, Department of Medicine, University of Pennsylvania, Perelman School of Medicine, Philadelphia. And Douglas J. Weeb, PhD, Epidemiology and Biostatistician Consultant, Department of Biostatistics and Epidemiology, University of Pennsylvania, Perelman School of Medicine, Philadelphia. References. 1. U.S. Senate Committee on Foreign Relations, Subcommittee on Western Hemisphere, Transnational Crime, Civilian Security, Democracy, Human Rights, and Global Women's Issues. Attacks on U.S. diplomats in Cuba. www.foreign.senate.gov web link. Published January 9, 2018. Accessed February 8, 2018. 2. Goodglass H., Kaplan E., Baresi B. Boston Diagnostic Aphasia Examination. 3rd ed. Philadelphia, Pennsylvania, Lippincott Williams and Wilkins, 2001. 3. Delis D., Kramer J., Kaplan E., Ober B. The California Verbal Learning Test, CVLT2. 2nd ed. San Antonio, Texas, Psychological Corp., 2000. 4. Brown S. G., Roy A., Rorla, Snyder B.R., Bryden P.J. Preference and Performance Measures of Handedness. Brain Cogn. 2004 55 2, 283-285. PubMed Google Scholar Crossrev. 5. Tom Botien. Test of Memory Malingering. North Tonawanda, New York, Multi-Health Systems, 1996. 6. Wright and R. The Validity of the Trail-Making Test as an Indicator of Organic Brain Damage. Perceptmo Skills. 1958 8 to 276. Google Scholar Crossrev. 7. Wexler D. Ways for Technical Manual. New York, New York, Psychological Corp., 2008. 8. Chlebovsky C. Wexler Memory Scale All Versions. New York, New York, Springer, 2011. Crossrev. 9. Bachat, Stira, Brown G.K. Beck Depression Inventory Manual. 2nd ed. San Antonio, Texas, Psychological Corp., 1996. 10. Bachat, Epstein N., Brown G., Stira. An Inventory for Measuring Clinical Anxiety, Psychometric Properties. J. Consult Clin Psychol. 1988 56 6, 893-897. PubMed Google Scholar Crossrev. 11. Bachat, Stira. Beck Anxiety Inventory Manual. San Antonio, Texas, Psychological Corp., 1993. 12. Grace J., Malloy P.F. The Frontal Systems Behavior Scale, FRSP. Odessa, Florida, Psychological Assessment Resources, 2002. 13. Weathers F.W., Huskia, Keen Trademark. PCLC for DSM-4. Boston, Massachusetts, National Center for PTSD Behavioral Science Division, 1991. 14. McCutcheon Park, Freedom C., Low EC, Belcher B., Engel CC. Rescaling the Post-Traumatic Stress Disorder Checklist for Use in Primary Care. MilMed. 2016 181-9, 1002-1006. PubMed Google Scholar Crossrev. 15. Risley DM, Marchetti GF, Kuharski DK, Whitney SL. Reliability, internal consistency, and validity of data obtained with the Functional Gait Assessment. FISTHER. 2004 8410, 906918. PubMed Google Scholar. 16. Paola, Myers AM. The Activities Specific Balance Confidence, ABC, Scale. J. Gerantala Biolsci MedSci. 1995 50A1, M28 M34. PubMed Google Scholar Crossrev. 17. Bell Drive, Gusquich KM, Clark MA, Padua DA. Systematic Review of the Balance Error Scoring System. Sports Health. 2011 33, 287-295. PubMed Google Scholar Crossrev. 18. Hornpound, Rice T., Stoskus JL, Lambert KH, Dan and Bami, Shearer Mr. Measurement Characteristics and Clinical Utility of the Clinical Test of Sensory Interaction on Balance, CTSIB, and Modified CTSIB in individuals with vestibular dysfunction. ArchPhysMed Readable. 2015 96-9, 1747-1748. PubMed Google Scholar Crossrev. 19. Shumway Cook A., Horak FB. Assessing the Influence of Sensory Interaction of Balance, Suggestion from the Field. FISTHER. 1986 6610, 1548-1550. PubMed Google Scholar Crossrev. 20. Jacobson GP, Newman CW. The Development of the Dizziness Handicap Inventory. Arterolaryngol Head Neck Surg. 1990 116-4, 424-427. PubMed Google Scholar Crossrev. 21. Alama Urika, Marchetti GF, Sperto PJ, Furman JM, Whitney SL. Estimating Postural Control with the Balance Rehabilitation Unit, Measurement Consistency, Accuracy, Validity, and Comparison with Dynamic Posturography. ArchPhysMed Readable. 2014 95-1, 6573. PubMed Google Scholar Crossrev. 22. National LM. Computerized Dynamic Posturography. In, Jacobson GP, Newman CW, Cartuche J. M., eds. Handbook of Balance Function Testing. Street Louis, Missouri, Mosby Yearbook, 1993-280 304. 23. Baron K. Interpretation and Usefulness of Caloric Testing. In, Jacobson GP, Shepard and T., eds. Balance Function Assessment and Management. San Diego, California, Plural Publishing, 2008-229 249. 24. Shepard N., Telian S. Practical Management of the Balance Disorder Patient. San Diego, California, Singular Publishing, 1996. 25. Shyman M., Wickby. Clinical Management of Binocular Vision, Heterophoric, Accommodative, and Eye Movement Disorders. 4th ed. Philadelphia, Pennsylvania, Lippincott Williams and Wilkins, 2014. 26. Galloway M., Shyman M., Mitchell G.L. Vision Therapy for Post-Concussion Vision Disorders. Optom Vis Sci. 2017 94 1, 6873. PubMed Google Scholar Crossrev. 27. Rousem, Borsting E., Mitchell G.L., et al., Convergence Insufficiency Treatment Trial, CITT, Investigator Group. Validity of the Convergence Insufficiency Symptom Survey, a confirmatory study, published correction appears in Optom Vis Sci. 2009 86 6, 786. Optom Vis Sci. 2009 86 4, 357 363. PubMed Google Scholar Crossrev. 28. Garza R.P., Richmond G., Nicholson S.P., Gaines C.S. A new visual verbal saccade test, the Development Eye Movement Test, DEM. JAMA Optom Associates 1990 61 2, 124 135. PubMed Google Scholar. 29. Mucha A., Collins M.W., Elbin R.J., et al. A brief vestibular, ocular motor screening, VOMS, assessment to evaluate concussions, preliminary findings. MJ Sports Med. 2014 4210, 2479 to 2486. PubMed Google Scholar Crossrev. 30. Johnson v., Stewart W., Smith D.H. Axonal Pathology in Traumatic Brain Injury. Expneral. 2013, 246 hours 35 minutes 43. PubMed Google Scholar Crossrev. 31. Alderfer B.S., Arsnegas D.B., Silver J.M. Treatment of Depression Following Traumatic Brain Injury. J. Head Trauma Readable. 2005 26, 544 562. PubMed Google Scholar Crossrev. 32. Brian R. Post-Traumatic Stress Disorder vs. Traumatic Brain Injury. Dialogues Clin Neurosi. 2011 13 3, 251 262. PubMed Google Scholar. 33. Jorge Re, Arsnegas DB. Mood Disorders After TBI. Psychiatric in Northam. 2014 37 1, 1329. PubMed Google Scholar Crossrev. 34. Jones D.F., Gray Gaz, Hoy D., et al. Mass psychogenic illness attributed to toxic exposure at a high school. N. Engel J. Med. 2000 342 2, 96 100. PubMed Google Scholar Crossrev. 35. Weary. Mass sociogenic illness. Maj. 2005 172 1, 36. PubMed Google Scholar Crossrev. 36. Shenton-Me, Hamodam, Schneiderman J.S., et al. A review of magnetic resonance imaging and diffusion tensor imaging findings in mild traumatic brain injury. Brain Imaging Behav. 2012 62, 137 192. PubMed Google Scholar Crossrev. 37. McInnes K., Friesen C.L., McKenzie D., Westwood D.A., Bo S.G. Mild Traumatic Brain Injury, MCB, and Chronic Cognitive Impairment, a Scoping Review. Flows 1. 2017 12 4, EO174847. PubMed Google Scholar Crossrev. 38. Beigler ed. Neuropsychology and Clinical Neuroscience of Persistent Post-Concussive Syndrome. J. Neuropsycholsoc. 2008 14 1, 122. PubMed Google Scholar Crossrev.